I have another disclosure. I'm not a health economist, so this has proved quite a challenging talk to give. I'm a clinician, but I've certainly got very interested in this, and after I got the call from Claudio, obviously there were some celebrations. This slide was for Mink. This is the FA Cup final last weekend when Theo Walcott scored. So I felt pretty pumped up when I got the call. Then I started to have a little think about this. How am I going to put this talk together? What do I know about health economics? So I spent quite a lot of time thinking about this and trying to put together a presentation which I hope you'll find interesting and stimulating. So I'm from Leeds, which is in the north of England. I work across Leeds Teaching Hospitals, the second largest trust in the UK. I'm the AKI lead and also oversee the renal replacement therapy program across the intensive care units in Leeds. And I must say I've been inspired by Claudio Ronco over the years and this concept of critical care nephrology, and it's inspired us so that locally we have our own regional conference now, critical care nephrology, which is there for the nurses and the healthcare professionals and so forth. We had our second one earlier this year, and we hope to go forward with our third in future years. So, the outline of my talk: what is health economics? Why is it important? What is the incidence of acute kidney injury? What are the costs related to acute kidney injury? And how could health economic evaluation of biomarkers and new therapies facilitate their introduction into routine clinical use for acute kidney injury? So health economics is a branch of economics concerned with issues related to efficiency, effectiveness, value, and behaviour in the production and consumption of health and health care. And I think we need to know something about this. So I'm not going to have too many definitions, but certainly this is a term that I think you need to understand. Incremental cost-effectiveness ratio. A statistic used in cost-effectiveness analysis to summarize the cost-effectiveness of a healthcare intervention. It's defined by the difference in cost between two possible interventions divided by the difference in their effect. And there's an equation that goes along with it. The ISA has been adopted in relation to the QALY, so that's the Quality Adjusted Life Years. And in the UK, NICE adopts a nominal cost per QALY threshold of about £30,000. So if an intervention goes above that cost, then you have to think quite carefully as to whether this is something that will be introduced into healthcare practice in the UK. And having settled on two NICE guideline developments over the last few years, I'm well aware of the emphasis they put on that. So I had had exposure to health economics, so I really hadn't realised what sort of exposure I really had. So this talk enabled me to narrow this down and really start to make it more applicable to what I do. It's used as a method to contain healthcare costs without adverse health consequences. A little bit debatable, that bit. And then in the USA, they don't necessarily hold to that. Provides information on where resources should be allocated when they are limited. New clinical trials should be encouraged to integrate ISA into results to provide more evidence of their potential benefit. And therefore, we may be able to see a way to get them into our everyday practice, if that's done up front. So why is it important? Well, look at the NHS, and speaking to Salvatore and other colleagues around Europe and the USA, health economics is very important. In the NHS, we have efficiency savings of £22 billion over the next 5 years. In Leeds alone, we have a 60 million efficiency savings to put over the next year. And in the renal department, our own department, we have a budget of around 30 million. We have to make a saving of 1.2 million on top of the saving we made last year. So how are we going to do this? We really need to think carefully about health economics. What's the incidence of acute kidney injury? We know it's increasing. There's a number of papers out there that demonstrate this. What about the global aspects? We've now got an initiative with the ISN looking at acute kidney injury globally. This was a slide which demonstrates in the USA that 1.2 million people per year get acute kidney injury during a hospitalization. That's 3.5% of admissions, $9 trillion. They stay in hospital 12.5 days longer. There's an increased risk of death. And the death rate per year is more than breast cancer, prostate cancer, heart failure, and diabetes combined. Pretty strong case. So, what's zero by 25? Zero preventable deaths from acute kidney injury by 2025. An ambitious target. Very ambitious. But something that we need to try and embrace and take forward. AKI is a global burden. It's become a challenge with an estimated 13.3 million cases every year. It's particularly high in the developing countries, where the incidence is around 11.3 million cases, that we know of, where it's measured, where they have a creatinine-based measurement, or they look at the urine output, or the patient can actually get to the hospital. Of 1.7 million deaths per year of AKI globally, an estimated 1.4 million of those deaths that we know of are in low middle-income countries. This was a publication in March in The Lancet, and Richard Horton has been very supportive of this human rights initiative. So I'll draw your attention to that publication if you want to know more about it. It's a lot of hard effort has gone into this, and there's a lot more work to do. What are the costs? This is a paper by Marcello Tonelli. This is a Canadian paper. This is back in 2009, an economic evaluation of continuous renal replacement therapy in acute renal failure. So this should just give you a few examples. So it compared CRRT versus intermittent therapy on the ICU. Similar patient outcomes, but the cost of CRRT was more per patient. However, the sensitivity analysis demonstrated that cost effectiveness is affected dramatically if you can change the risk of mortality or you can change the risk of long-term dialysis. So therefore, this is the key point. Future interventions to improve renal recovery are likely to be cost-effective, even if very resource-intensive. And that's what Marcello has told us. I think that's an important point for us to consider working together with pharma. This is a paper produced by colleagues in the audience. The economics of dialysis dependence following renal replacement therapy for critically ill acute kidney injury patients. And they looked at the upfront cost. The upfront cost was more for CRRT, but the 5-year cost, including the cost of dialysis dependence, was marginally less. There was a marginal gain in the QALY, and this was due to a reduced rate of long-term dialysis dependence on those patients who received CRRT as opposed to intermittent. This is a European paper, the 5-year cost-utility analysis of acute renal replacement therapy. Analysed together intermittent and continuous therapies, 5-year cost-utility, the ratio was €271,000 per QALY. That goes well above what we would consider something that we would fund in terms of NICE. This becomes acceptable in patients with renal recovery surviving for greater than 1 year. That brings it right down. So we're in a position, we're not going to stop giving renal replacement therapy to people in ICUs. No, we're not. But in terms of bringing in new therapies, we need to meet this bar, whatever that bar is. What about treatment of acute kidney injury in the developing world? Well, this is a paper that looked at the cost. This is Charles Swampole and his group in South Africa. I think this is very pertinent to what's going on in the developing countries. The cost of providing PD, the costs be around training staff, insertion of catheters, fluids, episodes of peritonitis, treatment of, etc. PD cost is 50% of HT in South Africa, hemodialysis in South Africa, but only if the fluids are produced locally. Increased costs if imported and have to be transported across borders. So that's a rate-limiting factor. What about the ISN 0 by 25 initiative? Well, we need to develop a cost-effective model to engage the politicians so they see that acute kidney injury is worth treating. Acute dialysis for 1 to 2 weeks is life-saving and is affordable in these countries. And then Sean Bagshaw produced this nice paper in Nature Reviews Nephrology. And Sean reminds us that the incidence of acute kidney injury is increasing, probably related to age, increased exposure to risk. We've heard a lot about this. And there are few proven preventative or therapeutic interventions. Survivors have increased healthcare costs, CKD, long-term RRT, and reduced quality of life, importantly. What's experienced in the UK? Well, the first hemodialysis unit, I'm very proud to say, was in Leeds, the artificial dialysis unit, which was Frank Parsons. So Frank Parsons was a very ambitious man, and he had the nerve to do this. He brought a dialysis machine across from the States, and as it was travelling across, he was called by the Medical Research Council, and he was told, try it, Parsons, but remember, the country is against you. And the cost of that machine, £5,500. Astronomical cost in those days, but he was bold enough to step forward and do it. And where are we now in England? We haven't had that referendum that separates us from Scotland, but our health services are somewhat different in terms of the way we gather the data. So it's a study of the economic impact of acute kidney injury in England by Donal O'Donoghue and Marion Kerr. So this is a study I just shared with you. In 2010-2011, the hospital episode statistics, which records episodes of AKI, and it's badly recorded. We've heard that already. Knusha has demonstrated us that recording of AKI may not be as good as it could be. 140,000 cases of AKI recognised in the UK, in England. That is 2.4% of the admissions. That doesn't sound right. Often AKI not recorded. Data from East Kent Hospitals, which is a hospital where Paul Stevens works, and they've always been very ahead in terms of gathering electronic data. AKI in their admissions were 14.15%, and that was adjusted. If you extrapolate this across England, then there should be around 785 cases of AKI. This is where health economics is important, or describing the instance is important to get the health economics around it. In-hospital mortality rates, well, 28% of people recorded by HES statistics die with AKI, and mortality rate increases as the age of the patient increases, not surprisingly. So what about length of stay and mortality? Well, length of stay has increased by a factor of 2.57, reiterating what we've already heard, and the relative risk of death if you have AKI is 4.69. What's the cost of AKI to the NHS? This is how we've leveraged things in the UK in terms of the programs we have now around acute kidney injury. The length of stay is 10.5 days longer for similar patients without AKI. Critical care use is higher, and we have a real lack of critical care beds in the UK. Our SOFA scores are very high on those patients that get to the ICU, and decisions have to be made carefully. It's estimated in 2000, data that we already have, estimated 11,000 to 12,000 people a year need short-term RRT for AKI. So what's the estimated expenditure related to AKI? If we look at the total inpatient care, extrapolate that from the HES data to the East Kent Trust, where they have some very good granular data, that's about £1 billion in a year. And then what about post-discharge care? Around £179 million. That's very, very informative. What about preventable deaths in English hospitals? This is a problem that is around us wherever we are. Based on HES data, 140,000 cases of AKI. If you assume, from Paul Stevens' paper, QJM a number of years ago, 20 to 30% are preventable. 20% were avoidable in the NC-POD study, patients who died with AKI. That would mean there's 28,000 to 42,000 preventable cases of death in the UK associated with AKI. If 28% of these patients die, then there's 8,000 to 12,000 preventable AKI-related deaths per year. What about the economic impact of AKI in England? Well, the annual cost of AKI is 1.1% of the NHS budget with these statistics. The costs do not include community acute kidney injury, patients who get AKI in the community that are looked after by the primary care physicians, because that's happening more and more as we've pushed our patient safety campaign into the community. Prevention of 20% of cases could provide 20 to 30 extra nurses at every acute hospital in England. So the cost of ignoring acute kidney injury, £1.02 billion per year in England. And what was the newspaper article that greeted this? Kidneys only get on front page newspapers if it's a kidney transplant, and I'm a transplant physician, so sometimes that happens, or if it's something bad. We need some good stories about acute kidney injury. So this was the headline in the Telegraph, one of our national broadsheets, thousands dying of thirst and poor care in the NHS. And that's in a developed country. Is there a role for biomarkers? So let's shift gear a little bit. This is a nice paper by Andrew Shaw, The Economic Impact. This is the sort of work we need. And cost effectiveness of urine neutrophil gelatinase-associated lipocalin after cardiac surgery. We've got new kids on the block. We've heard a little bit about these. They're looking at early diagnosis. Importantly, renal recovery. We know that's important, renal recovery, in terms of the cost benefits. We have the frusemide stress test for the prediction of AKI severity. How can we look at these and understand whether they work? Well, in Leeds we have the National Institute of Health research-funded Diagnostic Evidence Cooperative. I'm the Associate Director of this particular group. And we're keen to look at the need, the clinical need, and the potential impact of biomarkers for acute kidney injury. And we've set up this pipeline where we want to try and work with industry and academia, look at drug selection and prioritization, and think about biomarkers, how they will help us in this pathway, clinical studies, to finally get adoption and implementation. The group worked very closely with NICE and NOCRI and other regulatory bodies in the UK. And importantly, you can see the outputs there of patient benefits and economic value. And we got funding from NIHR for our AKI diagnostics piece of work, and this is health economics. So yes, I am involved with health economics now. I do understand it a lot better than I did, and I think it's really important. And there we're looking at how to evaluate the potential for AKI diagnostics to enhance NHS care of patients admitted to ICU. We're assessing what I described before, the ICER, the incremental cost effectiveness ratio. We want to identify and prioritise further diagnostic development and propose efficient design for relevant future research. And these are the sort of pathways that the health economists put together. They want to look at the analytical validity of the diagnostic, the clinical validity, the clinical utility, and put this into a decision model which we will construct, which is put together with an evidence synthesis to give us a cost effectiveness. And that gives us an output in terms of, is this going to be reimbursable by NICE, in terms of will they support it, will the NHS look to introduce that therapy, that biomarker, into clinical practice. And they're waiting for us to perform this study now. NICE have hold on all of the possible work on biomarkers until we've put this forward to them as a completed report. It's the sort of work that NICE do themselves. The decision model we have has the various input parameters, gives us our decision model, which then gives us an ICER as the output. There will be levels of uncertainty, and we have to factor that into the model. And we construct this is just an example. It's not the completed clinical care pathway, but it's a pathway perhaps that a patient might take. We're focusing on the ICU, into the ICU in terms of what happens. It could be that the AKI is diagnosed before the ICU admission. So as I say, this is not the completed model. You can follow the patient through. We may get an earlier diagnosis with the biomarker. We may be able to risk stratify them to different therapies. This idea was great, I think, about what's the baseline blood pressure, just as important as the baseline creatinine, and what's happening with the patient's perfusion pressure now. Could there be a treatment benefit prediction further down the line? How does it help us monitor these patients? In terms of the recovery phase, they're going out to the community, but they're still at risk further down the line. And then you can take this information and look at various tests. You can put this into the model to understand how that biomarker may transform the way we're looking at patients. What about the utility of the model? Well, we're looking in ICU populations. We're going to look at a subpopulation of cardiac ICU. It could be applicable to other areas. We could take the model and look at the emergency department if we wished. And we want to evaluate diagnostics and therapeutics. And I think that'll be very important as we try and move forward to understand how we work with biomarkers and therapeutics in terms of optimizing the outcomes from these studies that are being performed. So, what are my conclusions? Well, the economics of AKI are complex, for sure, but they're significant and they're global. Economical evaluation needs to factor in downstream consequences of AKI, including long-term renal replacement therapy, chronic kidney disease, readmission rates, which we know is important also. There's no good sending your patient out after 4 days if they're just readmitted another week later. I was hearing from Salvatore, that's the sort of thing they're being pressured to do in his centre. Future development of diagnostics and therapeutics need to evaluate the cost effectiveness as well as patient benefits if the health systems are to remain economically viable as we go forward. I'd like to thank you for your attention.